I'm doing it without my glasses, people, so. So happy to be here. Thank you. CommunityRx is an intervention that was developed with a Round 1 Healthcare Innovation Award from the Centers for Medicare and Medicaid Innovation. When we wrote the proposal in 2011, SDOH solutions were not words on the tips of anyone's tongue. This award resulted in this disclosure slide. One of the expectations of the funding was that innovators showing signs of success would bring forth a sustainable business model. In our case, this required the creation of two entities, a for-profit technology company and a nonprofit youth workforce development company, and the details are in my bio. CommunityRx is an intervention based on theory. And there are two areas of theory that we draw on. Some of you who are health services researchers know the work of Ron Anderson. His model of health services use is enduring, and there is one factor in this model that he identifies as highly mutable lever for determining or changing health utilization and health outcomes, and that is enabling resource of the community. And you've just mentioned the HRSA definition, so thank you. We also draw on work from nurse scientists. Margaret Gray and colleagues at Yale give us a model of self and family management, which identifies evidence-based processes that, if addressed, can drive downstream health outcomes. Self-efficacy as an intermediate target, health and healthcare utilization as more distal targets. MAPP score is what we had when we saw the opportunity for the Healthcare Innovation Award. This was a community-wide effort to engage youth in gathering a systematic census of data about every business and organization open and operating to serve our communities on the south side of Chicago. Why couldn't we just Google it? Well, critical resources in higher poverty communities, 30 to 40% of the time, are invisible in mainstream data sources, so we would have overlooked critical assets. When the Innovation Award came along, meaningful use was a thing, remember that? And our colleagues Abel Coe at Northwestern and Fred Rockman with the Shytrek Center, and we had been putting heads together. Bashara Shukair actually was in some of these early conversations thinking about how can we make meaningful use for people and communities with health information technology. So I said, well, I can e-prescribe drugs really easily from my electronic medical record. Why can't I prescribe community? So we proposed that idea, we built algorithms, we used computational phenotyping, we built fully into the EMR workflow a way to prescribe community, and we did it for more than 113,000 people. And it was the phone calls I got in my lab at the University of Chicago from health systems saying, how do we buy this, that inspired us in part to found this new company. Just giving people good lists of referrals near them that were vetted and specific to their needs, 1 in 5 actually went to a place within 2 weeks that they'd never been to before. And most exciting, half the people use this information to help somebody else. So if we just quantify the impact of our interventions by measuring, with a regression analysis, the impact on the patient before us, we don't learn the impact that goes through the ripple effect through information spread. So we've published our work, and I can only briefly reference these studies, but you see the outcomes we've looked at. CMMI has hired third-party evaluators for all of its innovation investments, at least as far as I know, at least in round 1. RTI looked at CommunityRx and looked at healthcare utilization over 3 years, and we just published a pragmatic clinical trial finding a signal on a predetermined secondary outcome, which was self-efficacy for self-care. There are several CommunityRx trials underway. I would say that, like these other people, I'm a humanitarian who knows how to make it look like science. And that's important because if we can't scale and we can't give evidence to our interventions, they cannot be sustained. So a number of HHS agencies have invested in studying this intervention. It's low intensity, high scalability, low cost. And time will tell if it plays out. There are some factors. Now, this is a health system view. So community is another very important factor affecting translation of these interventions. In health systems where clinicians are working in a tightly coupled way with administrators, or I was at Harvard a couple days ago and they suggested operations professionals is a better word, whatever you want to call it. But when we're in tight coordination, we're early adopters of implementing solutions to connect people to the resources of our community and address these issues we've been talking about today. When we're not talking to each other, I think we're laggers. There are some different drivers, though, and this is my observation as a clinician in a health system that's been thinking about these issues and as a vendor for the company I founded. Clinicians are end users, but it's the administrators who are doing intake of technology-based solutions, and so those two need to come closer together. I, as a scientist and as a physician, I'm looking for peer review evidence to know if the thing works. My institution's looking for institution-specific ROI. I have moral distress, they have regulatory distress. I want to take better care of all patients. They're looking to lower costs for high utilizers. I'm looking for in my workflow. They're looking at dashboards of apps that I could choose from. So I look forward to the conversation. Thank you so much.